Go?
Yes.
Good morning. Good morning. Good morning. Good morning. Thank you. Buenos dias. Bom dia. Bonjour. My name, good morning. Welcome to the Pan American Health Organization. My name is Paulo Lira, and I have the honor to introduce our guests today for the celebration of World Health Day at PAHO. I'd like to welcome Dr. Carissa F. Etienne, Director of the Pan American Health Organization, Mr. Bill Corr, Deputy Secretary, U.S. Department of Health and Human Services, Dr. Norman Campbell, President of the World Hypertension League, Dr. Sonja Angel, Senior Advisor on Noncommunicable Diseases of the CDC, Dr. Cristina Rabadan-Diehl, Acting Director of the Office of Global Health of the U.S. National Heart, Lung, and Blood Institute. Also joining us today at the table are Dr. John Andrews, PAHO Deputy Director, Dr. José Teruel, PAHO Assistant Director, Mr. Guillermo Birmingham, Director, PAHO's Director of Administration. I would like now to invite Dr. Etienne to give her opening remarks. Dr. Etienne.
Thank you, Paulo. Honorable Ambassadors, Mr. Bill Corr, Deputy Secretary of the United States Department of Health and Human Services, distinguished speakers, executive management team, colleagues, the media, good morning, welcome, and thank you for joining us today for World Health Day. I wish to especially welcome everyone who is participating remotely today from countries around the Americas. World Health Day is a special once-a-year event for us, a kind of birthday of WHO, a celebration that marks the founding of the World Health Organization in 1948. But it is also a serious occasion. Over the years, it has been the opportunity for us to focus on an issue that is a priority concern for global public health. Few would dispute the importance of this year's campaign, which focuses on the #1 risk factor for illness and death in countries around the world. In the countries of the Americas, it affects between 30 and 48% of the population. It strikes developed and developing countries alike without discriminating between rich and poor. We sometimes call it the silent killer. In its early stages, it often has no symptoms and as a result often goes undiagnosed. Yet, it is the leading risk factor for heart attack and strokes and can also cause kidney failure, blindness, and other health problems. In combination with other risk factors such as tobacco, harmful use of alcohol, obesity, diabetes, and high cholesterol, it becomes even more dangerous. Ladies and gentlemen, this silent, indiscriminate killer is hypertension. In the Americas, at least 1 in 3 people, and in some countries, nearly 1 in 2, has hypertension, meaning blood pressure that is 140/90 or higher. What are some of the reasons for this high prevalence? They include aging of the population, unhealthy diets, physical inactivity, and obesity, all of which, like hypertension and tobacco, are risk factors for cardiovascular diseases. Cardiovascular diseases are the leading cause of preventable and premature deaths and illness in the Americas around the world. But not all the risk factors for hypertension are behavioral. The risk of high blood pressure increases with age due to the hardening of blood vessels. But blood vessel aging can be slowed through healthy living, including healthy eating and reduced salt intake. So we know that behavior change is important, however difficult it may be to bring it about. And many of us know this difficulty. Many of us know the struggle with the weight gain. You will lose 10 pounds, and then in 6 months we are back with the 10 pounds are going up to 12. So it is a constant struggle. People's conditions, however, are heavily influenced by the conditions in which they live, work, play, and eat. Multi-sectoral approaches to address the underlying conditions have proven very effective in the prevention and control of hypertension. In this regard, public sector policies and regulations are fundamental to the prevention of chronic non-communicable diseases and their risk factors as hypertension. Low-income people are more exposed to risk factors, and at the same time, they have fewer resources to cope with health problems. For example, they do not have the resources very often to access health services or to access and to reach the benefits of social programs. They are also less able to protect their families from the disruptions that result from disability, loss of income, or out-of-pocket health costs. These are important considerations. In low and middle-income countries, many people do not seek treatment for hypertension because it is prohibitively expensive. Families can then end up spending a substantial share of their income on hospitalizations and care which is needed for complications such as heart attacks, stroke, or kidney failure. Indeed, millions of people fall into poverty every year due to catastrophic health spending or loss of family income due to death or disability, all as a result of hypertension and its complications. In all these ways, a condition that does not discriminate against rich or poor can and does have a greater impact on vulnerable people. And it has a negative impact as well on communities, societies, and entire economies as well. But the good news is that hypertension is both preventable and treatable. So what can we say to help people reduce their chances of developing high blood pressure? We can urge them to reduce their salt intake, to eat a healthy and balanced diet, to avoid the harmful use of alcohol, to engage in regular physical activity, and maintain a healthy body weight. For individuals, it is also vitally important to get the blood pressure checked regularly. And that's why we chose the slogan, Know Your Numbers. And this slogan was chosen for PAHO's World Health Day campaign. So I'm going to challenge all of you, certainly in PAHO, today and throughout next week, challenge each other. Do you know your number? ¿Conoces tu número? Let's challenge each other. We may actually be saving the life of our colleagues. So do you know your numbers? This is a personal responsibility, but it is also a professional responsibility for doctors, nurses, and other healthcare workers. But in tackling hypertension, it is just as important to take action at the population level. In the Americas, some of our member countries are doing just that. Countries like Colombia have promoted physical activity through urban planning and transportation, and through the immensely popular ciclovías or Sunday bikeways. Bolivia and Ecuador both have strong healthy living initiatives that include active living and healthy eating. Like Peru, they are promoting their country's traditional cuisines as much healthier than the modern over-processed foods that are increasingly replacing traditional foods in people's diets. Argentina has worked with its food industry to reduce the salt content in breads and industrially processed foods, and now other countries are following in its footsteps. Mexico is pioneering efforts to remove junk food and sugar-sweetened beverages from schools and to promote healthy foods to reduce overweight and obesity in school children. Here in the United States, states such as New York, Pennsylvania, and Tennessee have similar initiatives that are showing real benefits. But in addition to these important prevention initiatives, it's also important to make sure that healthcare providers ensure early detection and treatment of hypertension. For hypertension, the most important goal is control. People who are diagnosed with hypertension can be treated and controlled over the long term, which significantly boosts their chances of having a long, healthy, and productive life. And make sure I'm not saying unproductive, and productive life. We do not have as much data from our region as we would like, but recent studies in Latin America show that control rates are generally low, ranging from some 12 to 41%. By comparison, Canada, Cuba, and the United States have control rates of more than 50%. But efforts in our region are starting to show returns. Costa Rica and El Salvador have improved the quality of primary healthcare services, including the care for hypertension and other non-communicable diseases. Chile has expanded its guaranteed coverage for these conditions, and Brazil is providing free medicines for hypertension and diabetes through its Popular Pharmacy program. A growing number of countries are taking advantage of PAHO's own strategic fund, which pools purchases of drugs to create economies of scale that make essential medicines more affordable. We take this opportunity to invite all of our countries to use the fund to purchase drugs for treatment of hypertension and other chronic conditions. In May, the World Health Assembly will consider a global NCD action plan for 2013 to 2020. This plan will provide a roadmap for WHO member states to address the non-communicable diseases and their risk factors, including hypertension, as well as a global monitoring framework that proposes a global reduction in high blood pressure of 25% by the year 2025. To support action towards this and other NCD goals, WHO has developed a cost-effective and affordable total cardiovascular risk approach that can be implemented in primary health care even in lower-income countries. We're also recommending evidence-based strategies to address behavioral risk factors such as tobacco use, unhealthy diet, physical inactivity, and the harmful use of alcohol. World Health Day gives us an opportunity to raise awareness of hypertension, but also, and this is just as important, an opportunity to move forward on non-communicable diseases, which are one of the greatest challenges for us in the 21st century. Our member countries in the Caribbean you thought I was going to forget the Caribbean. No, the Caribbean has been at the forefront of the fight on NCDs, and they have ensured that NCDs receive the attention that they deserve, and I wish to place on record our thanks for the inspiration of the Caribbean and their ability to get this matter addressed at the UN high-level meeting in 2011. All of us, public health advocates, health workers, the academic community, civil society, the private sector, families and individuals, each and all of us have a role to play in supporting this agenda. At the Pan American Health Organization, we will work to keep up the momentum of World Health Day throughout the 2013 calendar year and beyond, coordinating with other campaigns, including Wellness Week and World Days that are focused on other non-communicable diseases and risk factors, including tobacco, heart disease, kidney health, and diabetes. I look forward to your support for all of these efforts as the year goes forward, and I thank you again for being with us here today. I want to invite you warmly, all of you, PAHO and our other colleagues, to invite us to the walk, on the walk tomorrow, as we showcase hypertension and raise awareness. So tomorrow morning at 9:30, we will leave from here, and you are warmly welcome to be part of that action. Know your numbers. Conoce su número. Thank you very much.
Thank you so much, Dr. Etienne, for this inspirational and productive introduction. I should say that we are, in addition to people in this room, we are also connected to all our offices through virtual connections, and also to people across the region that are listening to us today, and they'll be able to pose questions when we have the panelists presenting. I should also say that today we have simultaneous interpretation. The interpreters are here, and later in the program, there will be parts of the program, particularly the first video, that is going to have segments in Spanish. So I encourage you to make use of your earpieces. You have all them in your desks, and here too you can find them, so that you can understand, and the translators are going to translate the videos, particularly the first video that has some segments in Spanish. Now, we're pleased to have the opportunity to hear our special guest, Mr. Bill Corr. Mr. Corr has served as Deputy Secretary of the U.S. Department of Health and Human Services since May 2009. Nominated by President Obama, he returned to HSS after serving as Executive Director of the Campaign for Tobacco-Free Kids. As Deputy Secretary, he is responsible for the operation of the largest civilian department in the United States government. Mr. Corr, thank you.
Good morning. First, I would like to congratulate Dr. Etienne on her successful start for your tenure here at PAHO. But I'm not going to be as easy as she was on you, because I want to know who here knows their numbers. Ooh, that's good. That's good. We have to be examples, and it starts at home, as they say. It's a real pleasure for me to be here to represent our department and to be alongside so many dedicated leaders, advocates, providers, partners, students to celebrate World Health Day. I know this will be an engaging and productive program, and I wish that I could be with you for the entire time, but it's a pleasure for me to be here to welcome you and say a few things. But first, I also have to recognize someone sitting here on the front row, Maria Gomez and her team at Mary's Center. You may not know, but Maria recently received the 2012 Presidential Citizens Medal here in the United States from President Obama. So I wanted to... The comprehensive community approach to community health at Mary's Center, which includes screening and prevention of hypertension, serves as an inspiring model for all of us who are working to improve the health and well-being of our families and our communities. So congratulations to you, Maria, for your work. I'd also like to recognize the extraordinary efforts of the Caribbean community in helping to bring non-communicable diseases to the attention of the world. PAHO and CARICOM in particular have been tireless leaders in emphasizing the importance of combating chronic lifestyle-related diseases, and the choice of this year's theme is a testament to your dedication. As you know, and as has been said, our theme is hypertension. It's a grave condition, but it's also one that highlights the tremendous importance of PAHO and other multinational organizations represented here today. We come from a variety of countries, and each of us have unique sets of health challenges. But non-communicable diseases like hypertension are a problem that we all face, no matter what nation we represent. And by shining a light on our common challenges, we are reminded of our capacity to meet them together. Today, non-communicable diseases, as you know, account for nearly 2/3 of global mortality. And tragically, almost 30% of those deaths strike people before they reach the age of 60. In addition to the loss of life, over the next 20 years, non-communicable diseases are expected to cost more than $30 trillion worldwide, dragging countless families into poverty and undermining economic growth in every country. When it comes to conditions like hypertension, the scope of the challenge before us is undeniably large. And so is our responsibility to do everything we can to address the problem of chronic non-communicable diseases, knowing that the progress we make on this front will lift up all people of the world. It's going to require a broad and sustained effort with input that crosses all the boundaries of our nations, our sectors, and our societies. In that regard, it's the kind of challenge that collaborative multinational organizations like PAHO and the World Health Organization are especially well equipped to take on. And that work, as you know, is well underway. Over the last 2 years, we've seen unprecedented levels of attention focused on non-communicable diseases and risk factors like hypertension. That's largely thanks to the leadership of PAHO, its member states, and the WHO. The action plans being developed both globally by the WHO and regionally by PAHO are taking into account the need for wide-ranging solutions that tackle risk factors from every angle. That means working with governments to increase access to early detection and treatment, working with individuals to take advantage of that access and maintain a healthy lifestyle, and working with the commercial sector to reduce sodium levels in food. That's the sort of broad-based action that's going to help the global community hit its targets of a 30% drop in salt intake, a 25% drop in hypertension, and a 25% drop in premature mortality due to non-communicable diseases by 2025. I want to commend PAHO for leading the way on this work through its Pan-American Action Forum for Non-Communicable Diseases, and for establishing multilateral consortium focused on dietary salt reduction, an effort that has already brought together private and public sector leaders from across the Americas. Reducing sodium intake, as you heard, is a critical part of fighting back against hypertension. And we'll need to keep promoting positive habits on the personal and nationwide level. But we also know that lifestyle changes alone won't be enough to tackle the rising threat posed by hypertension and other non-communicable diseases. We also need policy changes that promote healthy communities and improve access to preventive services and care. That's why here in the United States we're proud to co-sponsor the Universal Health Coverage Resolution that was adopted at the UN General Assembly in December. Of course, expanding access to prevention and care is chiefly the responsibility of national governments, but multilateral voices like PAHO and WHO can play a vital role as champions for universal health coverage. They have the expertise to support countries in working towards expansion, and they have the ear of the international community. And the world is going to need strong leadership on this issue. More than 1 billion adults suffer from hypertension across the globe, and they are counting on strong leadership from those who have the capacity to lead. Universal health coverage is not an end unto itself, though. It is an essential goal that will help improve health outcomes across the board. We believe it is a goal that can unify the world in its shared pursuit of better health. That belief is at the heart of our domestic efforts here in the United States. As you know, expanding access to health coverage has been one of the cornerstone goals of President Obama's agenda since taking office 4 years ago. And thanks to the Affordable Care Act, that goal is poised to become a reality. We're dramatically expanding Americans' access to quality coverage, putting new rules in place to prevent the worst insurance industry abuses, and reforming our system to drive down the cost of care and prioritize preventive health. One of the most important programs we've put into place to help bolster these efforts is our Million Hearts initiative. Million Hearts is a public-private partnership that is applying the same holistic approach to the fight against hypertension here in the U.S. that PAHO and WHO are bringing to the international stage. We launched Million Hearts in 2011 with the goal of preventing 1 million heart attacks and strokes over the next 5 years. We've already seen great progress in our efforts to improve access to effective care, educate the public about healthy heart behaviors, and bolster preventive services. You'll be hearing more about this initiative from Dr. Sonja Angel of the CDC later in today's program. We've also continued to support critical multinational partnerships, including the Global Alliance for Chronic Diseases, of which I know many of you are partners. And you'll be hearing more about that work from Dr. Rabadan-Diehl of the NIH later today. The NIH is helping to support the Alliance's efforts to curb chronic communicable diseases in South America and Africa, including the initiative it launched last year specifically to address hypertension. This is precisely the sort of work we need to continue as we look to address the epidemic of hypertension. Expanding access to coverage within our own borders, forging partnerships beyond our borders, and promoting better health everywhere. Those will remain the key ingredients as we ramp up our fight against chronic non-communicable diseases. And thanks to institutions like PAHO, we have a tremendous opportunity to meet this global challenge with the global response that it demands. We know that we can be effective when we bring our common ideas, our common resources, and our common vision to bear on a problem of worldwide concern. Let us always remember that hypertension is a preventable condition. It's not a lightning strike. It's not an unusual or a freak accident. It can be prevented, and countless lives can be saved if we continue to commit ourselves to the action course we're on. And this World Health Day is no better day than to mark the important milestones of that action while we recommit ourselves to the work ahead. We here in the U.S. look forward to the progress that we all will make thanks to the collaborations like the one taking place today. And we look forward to continuing our work together as partners in the years ahead. Thank you all, and best wishes for a very productive day.
Thank you, Mr. Corr. So this concludes the introductory remarks today. In a few minutes, I'm going to introduce our other speakers. However, we just got an urgent request from our Monitoring and Evaluation Department, and they want to know how well we understand the concepts that have been socialized here so far. So I would ask you please to raise your hands if you, by now, after these two presentations, by now if you understand already that 100/40, 100/90 is normal blood pressure. Please raise your hands if you understand that by now. Please understand. Yes, 1, 2. It's normal blood pressure. No, it's not. Yes, you're right. But I tried to trick you, and it did work well when we rehearsed this, but it didn't work so well now. However, we are convinced that there is a lot of confusion about what is the correct blood pressure level at all levels of society, educated, non-educated, Latinos, non-Latinos, all over the world. And I myself, I mean, when I was briefed to come to this road, I said I don't know my numbers. So I'm a target audience of this effort here today. So we are going to show a video that shows how much in our region this is still a confusing issue, and what is the amount of work we have to do, we have ahead of ourselves in order to educate people about the blood pressure. Thank you. Please use your earplugs if you don't understand Spanish.
¿Sabe qué es la hipertensión?
Sí, claro que sí.
¿Qué es?
Es cuando uno tiene la presión alta, la presión arterial alta.
¿Y sabe cuáles son sus números y sus valores?
Sí, 120/80 es el normal.
¿Sabe qué es la hipertensión o la presión arterial alta?
No. ¿Sabe qué es la hipertensión o presión arterial alta?
Sí, es cuando digamos se eleva un poco, digamos, lo que es la tensión.
¿Qué es la hipertensión?
La hipertensión es una enfermedad. Mira, no la tengo definida, pero yo soy hipertenso y bueno, el cardiólogo no me definió bien lo que es, pero me dijo que es cuando la presión sanguínea excede los límites de normalidad, ¿no? Que es 12/80. Yo con 14/90 estoy hipertenso.
¿Cuáles son esos valores o números que indican que esa persona tiene la presión arterial alta?
Bueno, eso como no me lo he tomado, no sé cómo sería.
¿Qué es la hipertensión?
Creo que una enfermedad circulatoria.
Es ¿cómo se llama? Un defecto congénito producido por el colesterol y las grasas y grasas.
¿Sabía que usted puede controlar su presión alta también?
Sí, obviamente, porque a mí me han dicho que en la farmacia ahí podría controlarme la presión, pero ¿de qué me sirve? Sí, hay veces si uno consigue para la comida, para comer algo uno, pero no consigue para el medicamento.
¿Alguien en su familia padece presión alta?
Mi madre y yo.
¿Usted?
Sí. Yo.
¿Y se controla?
Sí, yo tomo pastillas en Alapril y una para el corazón.
Do you know how to prevent high blood pressure?
Prevention comes with one eating healthy, exercise, and eating less salt, and no smoking for once.
Hipertensión es tener más tensión de lo normal.
¿Cuáles son los síntomas que usted tiene cuando tiene la presión alta?
Bueno, yo no siento nada. Como estoy tomando las píldoras, que me la receta en la clínica bíblica, la doctora Borbón, yo no siento nada.
¿Alguien en su familia padece presión alta?
Yo.
¿Sabes cuáles son los números?
Sí, 140/90.
¿Sabe cuáles serían 3 medidas o pasos que usted puede hacer para prevenir la hipertensión?
Sí, bajar el consumo de sodio es uno, hacer ejercicio y no estresarse demasiado.
Y es el asesino silencioso.
So, we have a lot of work to do. So without further ado, I would like to introduce our next guests. Let me first introduce Dr. Norman Campbell. Dr. Campbell is a professor of medicine, community health services, and physiology and pharmacology at University of Calgary, and is also a member of the Libin Cardiovascular Institute of Alberta. He is also co-chair of the PAHO WHO Technical Advisory Group on Cardiovascular Disease Prevention through Dietary Salt Reduction, as well as a member of the WHO Nutrition Advisory Group, and President-elect of the World Hypertension League. Dr. Campbell will speak today about hypertension and the global burden of disease. Dr. Campbell, thank you. Yes, yes.
Thank you. It's a great honor to come here and speak with you today, and also to wish PAHO WHO a happy birthday. I thought I'd start with the impact of hypertension on a policymaker and some of the way hypertension may have shaped the world. Some may recognize the center figure here, former President of the United States, Franklin D. Roosevelt, who's sitting with Stalin and Churchill, and they're negotiating the structure of the world as World War II is ending. At the time, President Roosevelt's blood pressure is 260 on 150 millimeters mercury. He's already had a history of cardiac enlargement and heart failure caused by hypertension. At the time of his negotiations, he is not thinking clearly, and the understanding is that he has hypertensive encephalopathy with his blood vessels in his brain leaking fluids, which is hampering his ability to negotiate. He subsequently dies of a fatal stroke caused by hypertension. So policymakers need to take heed. Why hypertension? We've heard on the previous remarks the massive disease burden of hypertension. It's estimated that people living in a westernized world, about 90% will develop hypertension if they live an average lifespan. High blood pressure is highly preventable and treatable. Prevention programs are largely cost savings. Healthcare systems reform towards chronic disease management can be cost saving if they're wisely implemented to cost effective. Drug treatment in high-risk individuals is cost effective, and in situations like people with diabetes can actually be cost saving as well. This slide from the Global Burden of Disease looks at the leading 20 risks for death globally. High blood pressure is the highest risk, accounting for about 9.3 million deaths a year and about 7% of disability globally. Now, I've highlighted in red arrows dietary-related diseases such as obesity, diabetes, dyslipidemia, and in blue I've highlighted direct nutrition diet-related risks. Notably, 11 of the 20 leading risks for death are either directly related to unhealthy eating or are caused by diseases that have a strong dietary component. If one actually adds up the dietary risks, they are the leading risk for death, disability, and life years lost in low-income countries, in middle-income countries, as well as high-income countries. This is a relatively important slide to understand. It's looking at the risk of dying from stroke or heart disease. But on that same axis, one has to understand that blood vessels are damaged as blood pressure increases, so virtually every organ in the body would be affected in a similar way. As the blood pressure increases, the risk of death from stroke or heart attack increases. Most of the population is still in a normal blood pressure range, and the risk, about half of blood vessel related disease, occurs in the normal range but not optimum. So on this slide, you can see if your blood pressure is 120 systolic, you're much better off than if your blood pressure is 130 or 139. So half of disease occurs in the normal population, and they can't really be impacted by clinical interventions. So preventative measures need to be taken. The hypertensive population, the 140/90 and above, accounts for the other half of blood pressure-related disease. If we look at the causes of hypertension, this is from an Institute of Medicine report, about a third is related to high dietary salt. Processed foods have less potassium in them, and about 20% is related to lack of potassium in the diet. About a third is related to being overweight or obese. Now, in analyses from PAHO countries, virtually all of the obesity epidemic can be explained by excess caloric intake. Sedentary lifestyles, excess alcohol also account for hypertension. But 80% of hypertension can be attributed to dietary factors, and that should guide policy. So some policy interventions include setting targets and timelines for reducing added sodium, saturated and trans fatty acids, and free sugars to processed foods with close government monitoring and oversight, and is judged to be more effective if it's regulatory. Implementing healthy food procurement policies where public funds are only spent on purchasing healthy foods. The private sector can also do this, and companies that introduce worksite wellness programs largely based on healthy eating save about $4 for every dollar they invest because their workers remain on the job. Implementing clear, transparent conflict of interest guidelines to ensure public health food policies reflect public health interests and are free of commercial bias. And as an academic looking at public health policies in food, I would say currently they're mostly in the interests of the food industry and do not represent the best interests of the public. We need to protect our children by banning advertising of unhealthy foods to children who can't understand the context of the ads, but it increases their demand for unhealthy foods that are advertised to them. We need clear, easy-to-understand food package labeling with health implications. It's very nice to put stars and smiley faces on food, but the actual fact is these are causing death and disability in large numbers of people, and people need to be warned about that. Taxing foods that have added sodium, saturated and trans fatty acids, and sugars should be done to recuperate the societal costs of these additives, death, disability, as well as indirect costs. Similarly, one could subsidize the cost and increase the availability of healthy food, in part to recognize the cost savings to society by keeping a healthy and productive workforce. Critical to monitor and evaluate the health of the food environment as well. Now, I was asked to highlight a couple of regional initiatives. The first is an effort from the Pan American Health Organization to reduce dietary salt. Reducing dietary salt is judged by the World Health Organization to be a best buy to prevent chronic disease and hypertension in particular. There is a United Nations goal of a 30% reduction in dietary salt by 2025. To aid this effort, PAHO created a regional expert group in 2009, and more recently a technical advisory group. It's to develop recommendations and resources to aid policy development and actions, and to provide technical assistance to countries and the region. The group has been very dedicated, passionate, and has represented government, civil society, and academia. The tools and resources that have been developed now form the standard for many of these resources around the world and are used in various different regions. They include products to how to monitor salt reduction programs, how to best use knowledge translation to make sure all parties are aware of the need to reduce dietary salt and what needs to be done, work with the food sector to reduce additives of salt to foods, to work with programs that fortify salt with iodine so that iodine deficiency disorders are not adversely impacted as dietary salt is reduced, to perform economic analyses so countries understand the economic benefits and health benefits of reducing dietary salt, and to make sure that there's an up-to-date scientific evidence base that would support the whole effort. When the program first started, there were 3 countries in the region that had, I would say, programs to reduce dietary salt that were in their infancy. Currently, there are many, many more countries, and they're illustrated on this slide. The ones in blue are more effective programs that are likely to impact dietary salt. The other ones will have to evolve further to be effective. These are just some publications that outline the different activities of this work group. That would be an hour talk in its own right. In Canada, we have a program to treat hypertension, and this is now under the leadership of Hypertension Canada. It's a recommendations process where recommendations are updated and evidence is updated every year. It's connected to an outcomes research group that identifies whether the program's working and what's not working, where the gaps are, to an implementation task force that then develops tools and resources to try to fill the gaps and to develop those resources for healthcare professionals, largely primary care, as well as the public. We also have a national NGO committee that tries to develop advocacy for public policy, as well as oversees a national hypertension strategy. Before 1999, Canada had very low treatment and control of hypertension, being 13%, and about almost half of Canadians with hypertension were unaware. After the introduction of this program, there were very large increases in awareness of hypertension as well as drug treatment of hypertension, so that now the control rate in Canada is 66%, with fewer than 1 in 5 people being unaware. More important than improving the treatment and control of hypertension is the impact on the lives of Canadians. This slide looks at the cardiovascular death rates in Canada. The program was started in 1999, and one can see that there was about a 5-fold increase in the rate of decrease of dying of stroke, the primary marker of hypertension. Similarly, a 5-fold increase in the rate of decrease of dying of heart failure, and a somewhat lesser reduction in the risk of dying of myocardial infarction. Very similar data for national hospitalization rates for these conditions as well. An evolving program that Dr. Angel will talk about that we're looking forward to with great results within the PAHO region is a Center for Disease Control PAHO collaboration to work on core medications and essential health services for blood pressure control. So my last remarks, hypertension is the leading risk for death and disability regionally and globally. The causes of hypertension are well known and are similar to those of other non-communicable diseases. The paradigm of using an acute care system for chronic health care and asking for voluntary food industry change has been costly. It's largely been ineffective, and it's really contributed to the current NCD epidemic. The way forward should be clear: saving lives, preventing disability, reducing health care costs, having a healthier, more productive workforce. But this requires a distinct paradigm change towards food policy that includes regulation and health systems reform to support chronic disease management. Thank you very much.
Thank you, Dr. Campbell. Our next speaker is Dr. Sonja Angel. She is Senior Advisor for Global Non-Communicable Diseases in the Center for Global Health at the Centers for Disease Control and Prevention, CDC. There, she provides leadership for global non-communicable disease strategies and policy and program development. Prior to joining the CDC, she directed the Cardiovascular Disease Prevention and Control Program at the Department of Health and Mental Hygiene of New York City. Dr. Angel's presentation is titled, "Together We Can Control High Blood Pressure." Thank you.
Thank you very much. It's really a pleasure to be here today on this very important day, and I thank PAHO and Dr. Etienne for this really important leadership that's coming from this region and this critical area. The call to act is global. The call to act is global, and the time is now. We are set as a world in May to make some very ambitious yet achievable goals and targets around non-communicable diseases, and one of those focuses on the reduction of raised blood pressure. That's a reflection of the recognition of how important having normal blood pressure is to longer and healthier lives. By 2025, the prevalence of raised blood pressure will be reduced by 25%. That's huge. That can make huge differences in our health. There's two ways that can be achieved. That can be achieved through making very important lifestyle changes and creating enabling environments where people can consume diets that are lower in salt and healthier for them. The other way we can achieve that is by controlling raised blood pressure in those who have them. Neither of them alone can achieve what we need to achieve, and we need to focus on both of them. The benefits from doing that are important and have other implications, because there are many dollars going into that are lost because of poorly controlled blood pressure that could be used in other areas to help advance health. And we're missing this opportunity. In fact, the costs of non-optimal control of raised blood pressure are estimated to be over $372 billion worldwide in 2001. This is a study from colleagues at Harvard. And that amounts to approximately 10% of the overall healthcare expenditures. In Latin America and the Caribbean, the direct healthcare costs were estimated to be over $10 billion in 2001. And if blood pressure levels remain unchanged, the healthcare costs over the next 10 years are estimated to be $1 trillion globally, $40 billion in Latin America and the Caribbean. That's the cost that we're paying for poorly controlled blood pressure. The prevalence is high in this region, and I think, as noted before, the estimates vary. This raises an important area that we need to pay attention to, in that we need to have a better understanding of the problem itself. But the numbers that we do have alert us to the fact that from 11 to 43% of our populations in Latin America and the Caribbean have raised blood pressure. Awareness is also varies, but is low. Treatment rates also vary from 10 to 88%, and when it comes to control, none of us are doing very well. So we share in this opportunity to improve the way we're behaving with respect to blood pressure control. The prevalence is 1/3 of adults, and that's set to increase. 1 billion people worldwide have this condition, but there's something that we can do, and we can do now, and that is why now is the time to act. But it's challenging. Because none of us are doing this well, there are great opportunities to improve, but there are many barriers that we face together. One of them is you think about controlling hypertension, and I imagine, though I won't ask you to raise your hand here, I imagine that maybe 1/3 of you in this room, maybe more, have raised blood pressure, have hypertension, and are challenged every day to take a medication. And you're going to be challenged to do that for the rest of your life. That's not easy. Our systems aren't set up as a healthcare environment necessarily to support the management of chronic disease. Still, we're living in a history of a healthcare system that was created to treat acute conditions. This is changing, and there are models, but the barriers exist. And with respect to medication adherence, some of the issues that we're facing not only in our region but globally, particularly in low and middle income countries, is availability of medications, the affordability of those medications, and the complexity of treatment. There are also barriers to the effective treatment delivery, and that is what our healthcare providers and our clinical systems face every day, which include complicated treatment algorithms that we're giving providers, and inadequate patient follow-up. There's some things that we've done very well as a global community, though, and we're doing better, and those have a history founded on our approaches to infectious diseases. So perhaps we can learn from some of the successes in infectious diseases and apply them to chronic diseases, and perhaps we can do that for hypertension. I want to note just tuberculosis and building on the lessons learned from tuberculosis. As we've addressed tuberculosis globally, one of the things that became evident very early is that there were patient populations that had TB that we weren't following. We didn't really understand. We didn't know who they were. We didn't know what they were getting. And so an approach to addressing tuberculosis that has been successful has been a structured approach, an approach where, through direct observed therapy, lists of patients are made, and those patients are followed over time, and we have a responsibility to cure and to know who those patients are. And that's been achieved and is being modeled through high-quality standardized care, where we're accountable for each patient and each outcome, where targets and indicators are set, where data is collected, it's evaluated, and it's reported upon. And those targets and indicators then define further actions and additional indicators that help expand services and help identify and treat more patients and reduce the burden of disease. And why can't we do this for chronic diseases? Why can't we do this effectively? So let's just take hypertension, focusing on it because we know how prevalent it is, and we know that there are effective and available medications now to treat and control any and every patient if we did it well. And let's just think about the pharmacologic treatment of hypertension, what we could do to standardize and simplify it, because really it's not rocket science. What we need to do is to be able to have the medications prescribed that are appropriate for those patients. We need to make sure that those medications are available, and then we simply need to make sure that those medications are taken every day. It doesn't sound very complicated, and I really don't want to suggest that this is simple. But what I do want to say is that if we focus in a very simplified way, there are strategies that we can employ, and if we do that effectively, we can control hypertension. So this is the call to action. Effective treatment has the potential to significantly improve global population health. The development of a strategy and a framework for standardizing the pharmacologic treatment of hypertension that is both feasible and flexible to have worldwide applicability should be developed. And the development of a strategy and a framework that acknowledges and supports the use of existing evidence-based guidelines for diagnosis and treatment of hypertension can be used. And so let me share with you a collaboration that we're focusing on now in Latin America and the Caribbean, Global Standardized Hypertension of Treatment Project. The purpose of this project is to support the development of a strategy and framework for standardizing hypertension and medication treatment to have worldwide applicability. It simply focuses on a specific core set of medications, making that small, specific set of core medications widely available, not to exclude other medications, but to just make sure that at least some set of key effective medications are available, and that there are mechanisms in place in healthcare delivery systems, effective components that are used to make sure those medications are used regularly. This is a regional collaboration to start. Certainly the intention is this will have global applicability, but we're starting in the region. The Pan American Health Organization, Centers for Disease Control and Prevention, and key stakeholders and organizations across the Americas are joined together to think and to work to develop this strategy. The vision of this effort is that together, focused, we can simplify treatment, deliver medications, and make control of hypertension an achievable goal for all of us. Thank you.
Thank you, Dr. Angel. Before moving to our next speaker, I would like to invite a colleague of ours here at PAHO to show us a little bit of the practical side of hypertension control. Please welcome Jenny Scher.
Hi, everybody. My name is Jenny. We're going to do a little bit of stretching. So in a few minutes, I'm going to show you what we're going to do first, and then we're all going to stand up, and you're going to do it with me. So the first thing we're going to do, we're going to take our shoulders back, and our arms back, and our thumbs out. The second exercise that we're going to do, we're going to open up, we're going to squat, and we're going to reach our knees. The third one that we're going to do, we're going to do our shoulders. We're going to rotate them. And the next one we're going to do, we're going to put one hand on one side, And we're going to reach with the other hand over your head, and you're going to stretch. Everybody up. All right, everybody up, everybody ready? Give yourself some room. All right, and let's go. Let's put our shoulders back. Relax your shoulders. Reach your arms back, your thumbs out, and hold it. And release it. One more time. Take it back. Relax your shoulders. Take your hands out, thumbs up, and release it. One more time. Take it back, out, and hold it, and release it. Open up, reach down in the squat, and touch your knees. And release it. One more time. Open up. Squat into your knees. And release it. Again. Open up. Reach down into your, and hold it. And release it. All right, let's get those shoulders moving. Ready? And 1. And 2. And 3. Reverse them. And 1. And 2. And 3, again, and 1, and 2, and 3, and reverse them, and 1, and 2, and one more time, and 1, and 2, and 3, and reverse them, and 1, and 2, and 3. Everybody, your hand to the right hip, your arm up. Reach over your neighbor and say hello. And relax. Other side, other hand. Reach over and say hello. And relax. One more time. Hand over. Stretch. And relax. Other side. Over. Stretch. And one more time. Take it over. Stretch and relax. Last one. Take it over. Stretch and relax. Now, let's have some fun. Everybody ready? Hips to the right, to the left, to the back, and to the front. One more time. Right, left, back, and front. Right, left, back, and to the other side. Ready? And left, and right, and back, and front, and right, and left, and back, and front. Good job, everybody. Great job.
Thank you, Jenny. I'm sure this is going to be one of the most memorable moments of this session today. Our last speaker is Dr. Cristina Rabadan-Diehl. Dr. Rabadan-Diehl is an expert on cardiovascular health. She serves as acting director of the Office of Global Health for the National Heart, Lung, and Blood Institutes. She is also the scientific manager for the National Institutes of Health within the Global Alliance for Chronic Diseases. Dr. Rabadan-Diehl will speak today about evidence-based strategies for cardiovascular disease prevention and control through global research networks. Thank you.
Thank you. Yeah. Thank you. I don't know about you, but I feel definitely much better. So thank you very much to the organizers for inviting me here. Muchas gracias. So I represent an arm of the Health Department of Human Services that really focuses on supporting and developing the evidence-based strategies for cardiovascular disease prevention, because this is the National Heart, Lung, and Blood Institute. And I wanted to share with you a few of our strategies that we have developed, and taking you perhaps a little bit back from what Sonia was talking about. Rather than talking about control, I'd like to bring you now a little bit earlier, before we actually develop hypertension. So how can we actually prevent hypertension? We've been hearing about that this is a disease that can be prevented. So prevention of cardiovascular disease, it really is a lifetime opportunity for all of us, for individuals, for families, for communities, and the healthcare system. And that is why we really need to take and model where we integrate the individual within the family, within the community, within really the healthcare system. So we have heard a lot about different risk factors, and we also have heard that these risk factors are really within an environment that it's very much determined by the social determinants of health, and all of us are really going to have to struggle not only on knowing the numbers, but knowing how we have to control those numbers within our realities. And I wanted to take you back to one of the programs that actually we started supporting back in 1994. This was a utilization of a cadre of public health individuals known as the community health workers or promotoras. This group of individuals are really members of the community and are normally trained particularly to deliver educational programs. And at that time in the United States, this is something that it was really not used. This is really an example how over the last 20 years, this whole program has evolved, really getting into the realities of our populations and how this program, together with other interventions, have gone globally. The vision of that initiative back then was to empower the community health workers to be an integral part of a public health approach to decrease health disparities in cardiovascular, lung, and blood diseases in underserved and minority communities. And I'm not going to walk you through this because you'll have the slides available at the website, but I just wanted to tell you that this program initially started in 1994 with a program called Salud para su Corazón, or Health for Your Heart, and it was targeted to the Latino community here in the DC area. And we, through focus group, we realized that we really didn't have enough educational materials for our Latino population. So through focus group, we developed a whole cadre of materials as well as intervention programs, training the promotoras for the delivery of those messages. Over the last 20 years, this whole initiative really has expanded across the country with partnerships through academic institutions. It also entered in partnership with PAHO, where we took this internationally through 3 Latin American countries. And currently, we now have many of these materials available that have been targeted not only for the Latino population, but also other minorities here in the United States. The key, perhaps, the key of the success of this program has really been partnerships. And my talk, it's really going to be stressing the need of partnerships. Partnerships that we engage with professional associations, with government agencies, including PAHO, academia, community-based organizations, clinic, and of course, the community health worker networks. And we have now been able to show through evidence that these interventions are effective in clinical outcomes. And I just wanted to bring your attention to this graph and really focus on the blood pressure one. So this is really showing the different levels of blood pressure on the participants. There were about 100 participants with different levels of blood pressure before the intervention with these community health workers, and what happened 6 months and 12 months after. And as you can see, it is not only a sustainable teaching and intervention, but also was able to reduce those individuals that were in the highest stages of hypertension stage 2 and hypertension 1, to really a more normal levels, which really shows the effectiveness of this intervention. And that is what we do. We really provide the research evidence that could be translated into the clinic for more effective interventions. Now, we do know that the issue of hypertension, and we've already heard about this, it's really not only a problem of the United States. Non-communicable diseases account for 60% of deaths worldwide, and 80% of those deaths are located in low and middle income countries. And we, as the National Heart, Lung, and Blood Institute, really provide international leadership and research training and education. And I will just very briefly tell you about 2 programs that we have taken globally to really address this issue of chronic non-communicable diseases, and particularly the issue of hypertension. Back in 2009, we established an initiative where we work with academic institutions to establish centers of excellence to combat non-communicable chronic cardiovascular and pulmonary diseases. This is a direct relationship from our organization, from the NHLBI, with organizations that are located in low and middle-income countries. Each center of excellence is currently enabling research capacity building, something very important. We really need to train in these areas the future researchers in cardiovascular and pulmonary diseases, as well as conducting what was really appropriate and the immediate needs of those countries. This map is just showing you the location of the 11 centers of excellence that we are supporting together with our partners, United Health Group. And as you can see, 4 of those centers are actually located in the Latin American region. I am not going to go through describing what each one of the centers are doing, because you not only have them here in the slides, but you also will have them available in our website, and I have the privilege to be the director of this initiative. But I will, however, highlight that while we have 4 centers in Latin America, really the regions that they are working go beyond those countries. For instance, the center in Argentina is also working in partnerships with institutions in Chile and Uruguay. Guatemala, even though the center is located at INCAB, has their activities in Mexico, as well as all of the Central American countries and the Caribbean and the Dominican Republic. Mexico is in the Colegio of Sonora. It has activity sites on northern Mexico and the U.S.-Mexico border, as well as Peru, in different really areas of Peru. You know, one of the advantages of working as a global network is that at the end of the day, you really end up with the whole being better than the sum of its parts. We've had this program for about 4 years, and it's amazing what this group of investigators have been able to do together. These are people that were in different parts of the world. They didn't know each other, and they were united under the umbrella of this program to start looking for what are effective interventions at the community level for their populations. And they have started exchanging a lot of information across the borders. And that is perhaps for us one of the important things that we want to highlight with networks like this. You know, science knowledge knows no borders, and one has to start providing platforms where that knowledge is really commonly shared, because this is a problem that we are all sharing globally. And to me, as the director of this initiative, one of the things that really has brought me a lot of pride is the fact that now the centers that were totally isolated before, and that many of them didn't even exist, are now not only being the leaders in the region for research, but are also interacting with policymakers and are being asked by the policymakers to sit around the table as the governments are starting to develop strategies against chronic non-communicable diseases. And of course, since this is a forum on Latin America, I am extremely proud to see how the three of the centers in Latin America, Argentina, Guatemala, and Peru, have joined forces in a common project that we are funding to determine the effects of mobile health technology to promote healthy lifestyle modifications so that one can focus on reducing blood pressure and prevent progression from pre-hypertension status to hypertension. Also, this program, when you build programs like this, that are really so unique, you have really the benefit of bringing other partners around the table. And we have really been extremely fortunate to have partners like the CDC come and work with us in this program. Medtronic Foundation, professional associations, and even some of the institutes that work with us in the National Institutes of Health have seen platforms like this as really an entryway for them to address other issues that are comorbidities with chronic non-communicable diseases, like, for instance, mental health issues. But when you think about partnerships, you know, who are the people that you need to partner? We, at the end of the day, are really a research funding agency. So if we really want to do something, if we really want to support the evidence base, we need to also partner with those that are doing similar things on those countries. So in 2009, we were one of the founding members of the Global Alliance for Chronic Diseases that is bringing together 8 different federal funders of research that together collectively account for 80% of the research funding around the world. And this organization identified hypertension as their #1 priority. And it's because of that that last June we launched a program aiming to reduce the impact of hypertension around the world. This is just simply, a schematic representation of all of the partners that are involved in this initiative. There are 15 community-based research projects that will focus on implementing effective approaches to control high blood pressure. The projects represent an investment of more than $21 million. There are, at the moment, 4 international partners that are part of this initiative. The research will be conducted in 15 different low-American countries, and you can see some of the Latin Americans represented. And we would like to welcome really other research funders around the world to join the Global Alliance, to join forces that we can make sure that we are making integrated approaches as we are building that research evidence. For us, international partnerships are crucial. We wouldn't be able to do what we do. They're crucial to fight this massive epidemic. All the nations really are feeling the devastating impact of NCDs. And consequently, we feel that we all collectively must be part of the solution. And this convergence of interest really, for us, presents an amazing opportunity, but it's also an exceptional challenge to those of us that are in the medical community. And actually, I will go beyond saying that while we are feeling really the impact of these diseases within the health sector, the solution is not only within the health sector. The solution, as it's been said before, is really in sectors that are outside the health sector. And that's why multi-sectoral approaches and multi-sectoral partnerships are so crucial. And I just wanted to leave you with a few pictures of just a third of some of our partners on this network. And this is a picture that we took in Antigua, Guatemala, when we had 2 years ago our steering committee meeting. And something that we are very interested in is building capacity in the country, particularly research capacity. So through these programs, each one of the centers are building the future generation of researchers in these regions. And what we do from the NIH is that we bring collectively all of these trainees to the NIH and present opportunities for them to get training, to cross-fertilize, and to then create this global community of the future that are going to help us all to combat chronic non-communicable diseases, and in particularly the preventable risk factors such as hypertension. And here is my contact information. I'm going to make it available up on the website, and I will be very happy to address your questions as well as to be able to connect you, if you wish, with any of these programs or any of the individuals. Thank you very much.
Thank you, Dr. Rabadan-Diehl. We now have a few minutes, and we can ask questions from here, or our people who are following us from the other countries, they can also write a question and send us a question. Yes, we only have a couple of minutes, so if you want to ask a question, please think about that right now. Chessa, please, and go to the microphone. If you want to ask a question, please approach the microphone. There is another microphone here. Chessa.
Thank you. Chessa Letter, Senior Advisor in Nutrition here at PAHO. I'd like to commend the organizers of this World Health Day session. It's been the best I've heard at PAHO, and commend our director for using the word junk food, which I think is an important word to use rather than unhealthy foods in many situations. I like to use the word sick rather than morbidity too, because I think also that's very explicit. My question is to the representatives we have here of the U.S. Department of Health and Human Services. Dr. Campbell, in his talk, emphasized the importance of policy in prevention. The U.S. Nutritional Assistance Program here in the U.S., commonly known as SNAP, formerly known as food stamps, serves 47 million citizens and non-citizens of the U.S., including many of the Latino population. It's a program for low-income persons to help them, obviously, purchase food. The only restrictions right now to the use of these food stamps are alcohol and tobacco. Many of the recipients are overweight and obese. The recent Washington Post ran an expose recently about the program, and every single person interviewed in the photos, they had junk food front and center of their monthly purchases. The governor of New York tried to get a waiver from the U.S. Department of Health and Human Services to restrict only the purchase of sugar-sweetened beverages from this program. That was denied. Do you see any possibility that this program could be revamped to address the purchase of junk foods because they cause sickness? Thank you.
It's directed to you. Is directed to? Yeah.
So I would say that we here at the table from HHS, I'm sorry that Mr. Bill Corr had to leave a little earlier. We represent global efforts and are not in a position to comment on domestic policy, simply because we're not engaged in it. So I can't give you an answer to that.
Yeah, actually, even from my point, I mean, the agency that I represent, you know, we are the research funders of research. So while, of course, a lot of the research that we support, we put in within the context of policy, and our efforts have been on trying to link that research with policymakers. You know, we really are not in a position of commenting nor influencing policy at the moment.
I just wanted to comment on junk food because I think that's inappropriate. It suggests they could be just thrown away. I think they're worse than that. We call them pathogenic foods or toxic food environments, which really suggests the death and disability that they actually cause.
Andrews.
Thank you. That was a great group of talks, and really want to thank you and express our appreciation. I put out a question for anyone on the panel to perhaps address. I heard the word pre-hypertension once, and I'd like to have that explained in more detail. How important is it for the common citizen to know about pre-hypertension and what impact that may have if knowledge were such that we know those numbers and perhaps even earlier up the chain of pathophysiology can prevent hypertension?
So it's a really, really important point, because I think perhaps a disservice that we've done in communicating the problems of blood pressure is to assume that there's a healthy and an unhealthy status. And you either have hypertension or you don't. And then somewhere in between there, this term pre-hypertension has come up. And it's a very, very important term. In fact, your risk for heart attack or stroke starts to increase at a systolic blood pressure of 115. That's well below this 140. So the point that needs to be made is that while when you get above 140/90, you do need to be working with your physician or your provider to find ways to effectively control your blood pressure through lifestyle change and in many instances through medication. That's absolutely true. That level is very concerning. But there's a level below there where all of us need to take action. And that is when your blood pressure, your systolic blood pressure, is above 120. So that's much lower, is what we call prehypertension. The point to take home for all of us is that every single one of us, whether your blood pressure is high or low, has an opportunity to invest in a healthier future by taking and making changes today. And for the most of us with blood pressure less than 140/90, those changes can be very thoughtful changes around changing your diet, decreasing salt, decreasing saturated fat intake, eating more fruits and vegetables, and through changing your activities daily. Think about ways that you can increase your activities during the day at work. Take the stairs. I know that elevator, it's very tempting, it's right there, but those elevators out there probably don't ever need to be used. Maybe once in a while. and getting increasing your activity in your life outside of work as well.
I think the other aspect to pre-hypertension is that it's a predictor of the actual development of hypertension. And if we look at people with a blood pressure of 130 to 139 or 85 to 89, that's about 20% of our population. And if you look at 4 years, 60% of them will have developed hypertension over 140/90. That's not necessary in hunter-gatherer societies and societies that eat less than 1,500 milligrams of sodium a day. There's no increase in blood pressure with age. And so this is a phenomena that we have created through processing of foods and environments that discourage physical activity.
Yeah, and I wanted to add, actually, building up on both of your points, that it's really been shown, on that progression from prehypertension to hypertension, that really lifestyle modifications can really prevent that. So, my point again on going back to the prevention. So, if you really start looking at the population level, how many of the people are within that range? In the prehypertension stage, and what are the opportunities here for prevention? It really opens a tremendous window of opportunity for action, even before we go into the control issue with the medication. Not to say that, of course, we don't have to address the control, but really from the prevention viewpoint, it really provides a tremendous opportunity through lifestyle modifications to control that progression from prehypertension to hypertension.
Thank you very much. Thank you all for the questions and for the panelists for the answers. We now move to another important part of today's agenda. Every year, PAHO recognizes a special individual or organization for exceptional contributions to improving health in the Americas. We do this to highlight not only their valuable achievements, but also the example they set for current and future generations of public health practitioners. This year, it is our pleasure to recognize a dedicated and passionate woman, Maria Gomez, who, in 1988, founded Mary's Center, a community-based clinic that provides healthcare, education, and social services to the multicultural residents of Washington, D.C. Maria came to the United States from her native Colombia at age 13. She studied nursing at Georgetown University and obtained a master's in public health at the University of California at Berkeley. Before establishing Maria's Center, she worked in hospitals throughout the D.C. area, from the emergency room to neurosurgery. She also worked at the D.C. Department of Health, the D.C. Visiting Nurses Association, and the Red Cross, where she directed community education programs and disaster relief services throughout the United States. In 1988, Maria started Maria's Center as a small basement clinic providing maternal and child care to about 200 mostly Central American immigrant women. Since then, Maria's Center has grown into a fairly qualified health center that provides health, social, and educational services to over 70,000 adults and children. Its beneficiaries are low-income immigrant families whose special linguistic and cultural needs would otherwise go unmet. Maria's Center would not have existed, and thousands of DC families would remain underserved without Maria Gomez. In honoring her, PAHO is not alone. She has been the recipient of a number of awards, including this country's second highest civilian honor, the Presidential Citizens Medal, which was presented to Maria by the President of the United States and by the First Lady Michelle Obama in 2012. We're now going to see a short video about the center.
So this is terrific. Thanks for bringing it out. Aren't you guys excited?
And to see Mary Center grow to what it is today, it's just phenomenal.
Twins Person and Jason were born in 1997. Their mother, Elizabeth Lopez, was excited to be a mom, but unprepared to hear that Jason had Down syndrome. Mary Center was there for the Lopez family every step of the way. As a baby, Jason received care for his special needs through Mary Center's early intervention program. Mary Center helped Elizabeth enroll Jason in a school for children with special needs and ensured that she'd take advantage of all of the resources available to her family. Jason's brother Herson comes to Mary Center for regular medical checkups, and now that he is a teenager, participates in our after-school program. He also spends the summer at Mary Center in our youth employment program.
I have been in a program where they could help you do your homeworks, do community service hours, get credits, go places you had never been. That program has been like a second family to me.
Like Elizabeth, Tanya Marbach and her family found support at Mary Center when their son Hector was diagnosed with eye cancer at age 2. Hector is now a healthy, cancer-free second grader with an eye prosthesis, all made possible through the care of Mary Center. The Mary Center difference is clear to the people we serve. Our supporters see it, and it takes a community to sustain.
This center brings me joy. It's a dream realized. I just continue to be in awe of Maria Gomez, her staff, her wonderful, loving staff, and it excels and it speaks and spells excellence. And we owe our children and their families no less.
Help us continue to transform lives and create healthy futures. With your support, we can make the difference.
Please join me now in welcoming Maria Gomez to receive the PAHO Special Recognition from our Director, Dr. Carissa Etienne.
Thank you very much. And I know you've had the experts on talking to you about blood pressure, about staying healthy. And I just want to say to you that I think it is an extreme honor for me to receive this here today from an organization that does so much and exemplifies. I follow your lead. I've always had a dream of working at PAHO. So I created our own little sort of oasis in this community, and it's it wasn't named after me. I think the translation says Maria Center. It's a very, very long story. Politics, everything got involved in the way, and so it was named after the Mother of God for all the reasons that we know how things happen when politics and money and things come about. So, but I am very, very proud to be here this morning with all of you. I know that you've been sitting for a long time, but I think today I just want to say that we are very connected with the mission of PAHO in many ways. One of them, I think, is that on a much smaller scale, of course, is that we're committed to the health disparities, which every one of you have talked about. In the 3 pillars that you saw there, one of them is health care, to make sure that people that were there from the moment they're born to the moment that we're ready to leave this planet. The second is to make sure that we're there to support them in all of their social needs, as all of us, I'm sure, in one sometime in our lives have had to have a helping hand from someone. So whether it's domestic violence, mental health issues, whether it's affordability of paying rent, whether it's affordability to put food on the table, that Mary Center there to help families. And the third is around the issue of family literacy, to make sure that parents and the children together are learning so that their parents really are their children's first teacher and best teacher, which I think that for many of us sitting around this table, that's what we are for our children, and we should expect no less from anyone else around us in our most economically deprived community. So I think that if parents feel engaged and parents feel like they themselves are moving up the economic ladder every day by learning something, by knowing that they can provide for their children, or at least feel like someday they will be interdependent, that really is for us how we can manage at the end of the day the person being able to take the medication and follow the directions for their blood pressure. The second piece I feel very strong that we're connected with PAHO is the whole ability to mobilize partners, right? Can't do this alone, and it's so beautiful to see how PAHO does that and how the partners around this today, have brought so many partners to bear to this. And so when I come up here and receive this honor, it really is an honor of all of our colleagues at GW. I see some of our colleagues that we do research with here and some of our wonderful friends. We can't do it without them. We can't. We're sometimes so bogged down on making sure we provide just the services. And as you see, everything that I do is about fundraising. So I pardon to be showing a film about asking for money, but that has become almost 90% of my job. But it is our staff who really are every day making sure that they inspire me by what they do and with their ideas, and so that I can go out and fundraise. So as I was speaking to someone earlier, it's not always waiting for the money to come and then to think about the ideas, but continue, like all of you do every day, to continue to think and spark ideas so that then we can go and find the money. And so I know that with some of our partners at GW and some of you, I know this is exactly what you do in the government, is just a sort of a synopsis and a cataclysm of ideas. And so together I think we can bring lots of money to bear to make sure that, and I think that this president has shown that really he is interested in ideas, and then where can we put the money? And he has done that so wonderfully. And I think the last thing is I continue to urge PAHO to stay vigilant and to stay committed to our most fragile community throughout the world, and not to forget who they are. Many of us are at a level sometimes that is so high up that we forget. We forget that when you're in your office working on a project and when you're working on a research, it affects an individual so deeply, and you can make a difference for an individual, not only to live, but to inspire the next generation, like my mom did, and like many of your parents and grandparents did to you. So that is the first step, I think, is to inspire. And I think that all of you sitting in this room, all of you that have spoken today, are inspirational in so many ways. And the first thing we have to do is to inspire our children so they can become, right? They can follow in our steps of inspiring the next generation. And if a generation feels inspired, they can conquer the world. Many of you around here did not get born privileged. We're not born privileged. And you're here because someone in your life inspired you. And remember, sitting in that office today and every day, that you have an impact to do that. We have 3 generations at Mary Center that we have inspired, and that many of you, maybe you yourselves or your neighbors, have become volunteers, have become mentors to many of the families at Mary Center. And that is how we're going to change the world. That is how that individual is going to be inspired to go to the doctor, to hear what the 140/90 is, and to make sure that we follow those 3 steps that we said we're going to follow for this. And so inspiring the next generation, I beg you to please stay vigilant to that. I beg you to please don't forget the most fragile of all, and to understand that as fragile as they may be, as we may be at times, we have tremendous assets. Each individual has tremendous assets that we can take from and move them along to that economic ladder, because at the end of the day, we have to also educate the ABCs, educate a generation and generations throughout the world, an important piece to really change the health disparities in this world. Thank you so much. It's an honor to be here. Thanks, everyone.
Words I don't think we are going to forget anytime soon. Well, we are approaching the end of the celebration today. I have 3 announcements to make, 3 invitations in fact. The first one is that every year PAHO organizes a walk for health. And it's a very participative activity. Lots of people from the staff, but also our families and our friends, they come and we go together on the mall. This year is going to be tomorrow, starting at 10, but if you come at 9:30, you're going to get coffee, fruits, and you can also dance here. We're going to have music. It's a very lively activity, and it's getting better every year. And this year, they perfected it so much that we made it coincide with the peak of the cherry blossom in the mall. So it's really, really not worth coming for this. There are leaflets outside if you want to come. Please, otherwise we can give the information here. The second invitation is that after we finish here, we are going to have an inauguration and a reception. The inauguration, taking your advice, we are inaugurating an exhibit that motivates people to use the stairs in PAHO and not the elevators. I don't know why we have a new elevator, Dr. Birmingham, but maybe we shouldn't have spent money on that new elevator. But maybe it's good too. It's good too. But we are promoting the use of the stairs, and one way to do that is that we set up an exhibit in the stairwells of PAHO with 18 pictures of healthy behaviors from our region, healthy behaviors that come from our traditions, from our culture, and from our initiatives in our region. So this is to motivate people, and we are going to inaugurate just across from here. We are going to see the ceremony set up here. Please join us as we finish this for the setup. Then you can go up and down, and eventually you can go down for the reception. Lastly, I would like, okay, he wants to take my role.
Sorry, just went you.
Oh, yes. Sorry, I forgot that part. So you can see a little bit now pretending that we are going up and down the stairs, and we are not taking the elevator, so we can see some of the pictures that I was just mentioning. This is the poster of the campaign of the World Health Day, of course. And, you know, there's going to be plenty of opportunities. And we also have an article in our intranet site discussing and giving examples of PAHO staff who already use the stairs and why they found it so important and what are the benefits they get from using the stairs. Anyway, now, my last invitation today, first is for you to raise your hands, your right hand, please. Yes. Now, start moving it a little bit down and try to reach under your seat and see if under your seat there is a paper taped to the seat. So some of you are going to find something taped to your seat. And if you do, And you can check the seat next to you if the seat is empty too. No, I don't think the people in the head table are not included, I must read. So if you find those who found a paper, please raise your hands. Okay. And all those are going to get a prize outside this room. It can be either a T-shirt or a pedometer for you to also to exercise. A T-shirt, of course, is going to be the T-shirt of our celebration tomorrow. Well, thank you so much for joining us. It has been a wonderful morning. Thank you, thank you. Please join us just outside here for the inauguration of the exhibits, and after that for the reception. Thank you.